Hey guys, welcome back for another week of topics and tips. As promised, let's discuss diabetes this week. We'll be covering everything pertaining to type 2 diabetes, just the short and sweet foundation of it all, covering those oral medications and also insulin therapy. For those of you who typically follow the videos, welcome back, you guys. For those of you who are new to me, hello and welcome. I am Dr. Brittany Weinstock, family nurse practitioner and founder and CEO of the Nursing Studio. I do these videos to help nurses and nurse practitioners to prepare for boards as well as in practice. This is not an end all be all, but overall information to help you for exam readiness and success. Now, y'all bear with me. You can hear my voice sounding a little shaky. I don't know what's going on. I feel perfectly fine, but my voice is showing out on me, okay? But I make promises and keep them. So here I am. Let's get to it. All right. So let's just talk about what is type 2 diabetes, right? So, in the simplest terms, there is either too little of insulin production or there is some form of insulin resistance, right? And with type 1 diabetes, it's strictly that the pancreas is not producing enough insulin. That's the simplest way to tell you type 1 and type 2. Genetics plays a huge role in both. Type 2 also has so many lifestyle factors that are contributors. But when you think about it and what is that foundational cause, type 2 diabetes, there is either too little of insulin production or there is insulin resistance. With type 1 diabetes, the pancreas is not producing enough insulin, okay? So, how does that work? How do things even work in the body and what does that even mean, right? So, let's walk through it. So, I tried to kind of break it down to give you a picture. You know how I like to just give you the nitty gritty, take away the fluff, and let's make sense of all of this. So, starting out, you're eating, you're consuming certain things, and your body breaks it down into glucose in the bloodstream, right? And so then that glucose in the blood stimulates the organ, your pancreas, to release insulin. Now, the insulin, once then released, stimulates and targets the target cells, those beta cells, right? And those target cells then work to remove the glucose from the bloodstream and back into the cells in the body to be absorbed from that fashion, right? So, what happens with diabetes is that we have this glucose in our bloodstream and it stimulates the pancreas to release the insulin, and either the insulin is not producing enough or it's resisting, right? There's some type of resistance to have the level that you need. So the problem that happens then is that the cells cannot remove that glucose from the bloodstream to be reabsorbed into the cells to be utilized in our body for our energy sources to be metabolized correctly, right? So in that fashion, now all that glucose is building up in the bloodstream. Hence is how we get to hyperglycemia, right? So let's talk about what that even is. So here, breaking down hypoglycemia and hyperglycemia, you know our med terminology, hypo being low, hyper being high. So that's exactly what it is and what it says. So with hypoglycemia, that's when the glucose levels are low, typically less than 50 milligrams per deciliter. And then the hyperglycemia is when the glucose levels are high. So anywhere with the A1C being greater than 6.5%, the fasting glucose greater than 126 milligrams per deciliter, or, and I should say, and or your 2-hour plasma glucose being greater than 200 milligrams per deciliter. The reason I say and or, so when we truly have that diagnosis of type 2 diabetes, you typically have two of those listings that I just went over for adequate diagnosis. Now, with hypoglycemia, that glucose level is low. That can be very dangerous. It actually can be fatal if dropping too low and not taken care of. But the patient may tell you they're having a feeling of weakness. They may feel shaky, kind of anxious, lightheaded, dizzy, feeling as if they may pass out. And on the opposite end, with hyperglycemia, the common presentation, are those three P's: our polyuria, our polydipsia, and our polyphagia. So, meaning excessive urinating, um, being excessively thirsty, excessively hungry. That's what all of that is saying. So, things are increased as the body is trying to compensate and work through this increase in glycemia, the increase of the glucose levels. Okay. So, I want to recap really quickly before I get into the treatments. Okay. So we're starting from the top. So remembering that with diabetes, we're having a foundational issue with that insulin, right? So we either have too little insulin production and the insulin is not able to stimulate those target cells, right? And so with that, that alters the entire normal process of how our body and system works, right? So, starting from the top, we ingest and consume things, and glucose in the bloodstream then stimulates that pancreas to produce insulin. And the insulin should stimulate those target cells so that they can work to remove those cells from the bloodstream and absorb them back into other cells in the body to be produced and metabolized for the functions that we needed, and not to just allow that glucose to stay into the bloodstream, right? Now, because of um, diabetics having that deficit or issue with the insulin being able to stimulate those target cells, having lack of a production of the insulin, then we lead to needing assistance in those areas, right? So we have oral agents that we can utilize to help with the treatment of the diabetes as well as insulin therapy. So let's first get into the oral therapy and then I'll get into the insulin therapy, okay? So here, let's talk about a few. And there's so many medication and drug classes for the management of diabetes, but I want to hit on those common ones and kind of talk on those briefly to give you a better glimpse and understanding of those, okay? All right, so the first drug class are our biguanides, right? So with those biguanides, this is a very common class and commonly that first line therapy. So biguanides, a common one is that metformin, also known as glucophage. Biguanides are designed to work to prevent glucose production in the liver, to increase the sensitivity to insulin, and then to limit the sugar absorption in the intestines. So basically, it's trying to prevent the liver from producing more glucose. It wants your body to be able to increase the sensitivity to insulin so that it's responding to that normal process so that it's able to stimulate those target cells, and then limiting that sugar absorption in the intestines, right? Now again, I talked about metformin glucophage. That is our first line therapy. Is so helpful because this was one of those medications that's causing like quick hypoglycemia because of the design of how it works, and its mechanism of action. But we always tell you guys to make sure that you're telling your patients that the side effects of diarrhea. They can have stomach bloating, they can have a lot of GI responses, but one of the common things is the excessive diarrhea that they may have after taking it. And the instructions you want to provide to them is that to continue taking the medication for 2 weeks and the diarrhea should subside. But being sure not to use in patients who have hepatic or renal disease, okay? Now, second are our sulfonylureas, like our glipizide. Now, these work a little bit differently. It's an older drug class of medications, but used to be used a lot in the past. But it works to activate those cells to promote more of the insulin production. So think about that because it's going to give you the reason that I tell you that it isn't. It's used a little bit differently, and why the big guanides are that first line therapy. But if it's working to promote more insulin production, that means that you really have to pay attention to that glucose level, because what does insulin do? It's going to break that down, right? And so it can cause hypoglycemia. So you really need to pay attention to those levels. So that is why biguanides are a really great first line therapy, because you don't have that effect as much as well either. But sulfonylureas are great medications, used to be first line therapy. One of the first therapies a long time ago, I should say, because it's an older medication, but a lot of people like this medication too because it is a cheaper cost. So all of these things are great things to keep in mind when you are prescribing and preparing to treat patients. Now, same here though, do not provide these medicines to patients who have hepatic and renal disease, okay? And then third, the TZDs, right? So those actos. They work similarly to the biguanide drug class because they're working to prevent that glucose production and also increasing that sensitivity to insulin. Now, for these TCDs, now they can cause patients to retain water. So we do not want to give those to our congestive heart failure patients. So that's a key identifier. Please do not prescribe those to the patients with congestive heart failure. You don't want to increase the potential for water retention and edema. And also, you want to monitor their liver function because all of these, we don't want to give it to those patients who have hepatic disease or renal insufficiency. Okay. All right. So let's get into the insulins. So, y'all know there are various insulins. We have our rapid acting, our short acting, our intermediate, and long acting insulin therapies. There's so much more I can get into. Um, we have basal and bolus and all of that stuff. And I do have other videos on that, and I will share that in the description. But I just want to hit on these different types of insulin just to give y'all that foundation, okay? Now, with the rapid acting insulin, these are the ones that end in log, like our Humalogs, our Novalogs, right? But they're rapid acting, they have rapid onset. These are the ones you need to have their meal, because the onset is within 15 minutes after taking it, right? Now, short acting, their onset is pretty quick too. It's within 30 minutes, but it covers them around 6 to 8 hours. This is that regular insulin, like your Humulin, and you'll see it commonly like Humulin R. Now, our intermediate insulin, it's called intermediate because that's that one that really falls in between the coverage periods of those short acting and those long acting insulins, because it can cover from 6 to 14 hours. That's typically that peak time um, for their range on that insulin coverage. And so you'll commonly see those when you need that tie over, that intermediate phase of it. But NPH is your intermediate. You'll see that as Humulin N, and commonly that regular insulin and the NPH, those two can be mixed together. So you'll see that 70/30. That's the combination of the two medications, okay? And then lastly are your long acting insulin. Long acting is just what it says, right? It covers for the longest period of time of all of them because it covers you for a 24-hour period. And with these, I tell you to think of the ones because they're the L for long acting, L for your Lantus, L for Levemir. Those are our two of our long acting insulin therapies, okay? All right. So when do you start insulin, right? So when do we initiate? If they have an A1C of 10 or above, and we're just assessing this and they haven't been diagnosed, we're going through this is the first time their A1C is this high, we want to start initiating insulin therapy. Okay. And also if they've been on dual anti-diabetic treatments and their A1C is still to this level of elevation, you want to do insulin therapy. Now, knowing this, I also want to kind of give you some more little tidbits and thoughts on all of the medications, having that foundation knowledge, because when we're treating those patients with diabetes, as everything else, we start with lifestyle modifications. You want them to watch their weight, watch the intake of carbs, telling them to lower their carbs, those sugars, those breads, pasta, white rices, things of that nature. Okay. Also, recommending that they exercise frequently, 5 times a week for 30 minutes on each of those days. Now, again, metformin is that first line therapy. So if they're to a certain level, in that pre-diabetes phase, it is common that when we are doing this lifestyle modification, and if we're not seeing adjustments, you can implement the metformin in as well. It is great for this, and one of those medications that are best in that pre-diabetic phase and preventing them from actually being fully diagnosed with diabetes. Okay. Now, um, you can add sulfonylureas in with your metformin. So if you have maxed out that metformin dose, you can opt to add in a sulfonylurea, because also, like I said, you typically will see patients, and for testing purposes, prescribe two of the oral medications before we're jumping to insulin, unless that A1C is at 10 or greater. Um, Remembering with those sulfonylureas, you want to monitor the glucose closely because of that hypoglycemic effect. Also, sulfonylureas can cause weight gain. Also, the TCDs, remember, the TCDs are like your actose. Those two are commonly with weight gain. But remember, I told you with the TCDs that they can cause water retention. So it just makes sense on that weight gain factor when you think of all of that, all right? Now, metformin on the other end can cause weight loss, and people actually like it for that reason. But I just say all these things so you can monitor it, because you never want any of those things to be excessive. Um, Making sure, excuse me, sure that you are also with those patients monitoring their cholesterol levels, their blood pressure, their weight, their feet, and making sure they're getting their eyes checked annually, because these are things that can have secondary complications from the diabetes. All right, so that was just a quick rundown of what is diabetes type 1, type 2, and then really just kind of looking at the flow of things from type 2, and understanding quickly those drug classes, how to prescribe, what allows for the diagnosis of diabetes, and then the treatment. I will add my other videos in the description box too, and then I'll be doing some more of these in the future, because with diabetes, it's so many pieces. So if you have questions or some little areas you want me to cover, please put it in the comments, and I'm happy to do so. I don't like the videos to be too long, to be overwhelming, so I just wanted to hit the high notes, um, to kind of help you tie those pieces together, and the keys to look at, the common medications to work through. And as always, I will be doing some upcoming questions and things. But thank you guys for watching, and thank y'all for bearing with my voice this week. Make sure that you like, comment, subscribe, share with someone who might find this helpful. But be sure to meet me back here tomorrow so that we can work out a practice question to test your knowledge on these. And then to wrap up this month's series on our SOAP notes, we will also be doing one of those from the diabetes standpoint. Okay. All right, you guys. Bye, y'all.